meeting. I'm going to walk through for about 15 or 20 minutes the report that the county produced as of April 27th. I'm going to lead into that by telling you sort of the relationship between that report and the complex decisions that the county is now facing. At the end of that, we're going to stop for just a minute, get that screen out of the way, and behind it is our places for the 5 panel members sitting right here, who will be then telling you a little bit about themselves, but then what it is about that report, or what they think is missing in that report, that needs to be brought to bear on the decisions that the county has to make. And at that point, we're going to open up to all of you the opportunity to raise questions, either about the report, and there are 2 members of that report committee on that panel, or about issues that other folks will have raised in the course of their panel, or questions that you have about the future of Bergen Regional Medical Center. It's the largest hospital in the state of New Jersey, the 4th largest public hospital in the country, and a institution that plays an extremely complex and important role in our county. What you're looking at is actually the Google view of the 60 acres that now constitutes what Bergen Regional has available. This area over here on the right-hand side, which is actually the northeast portion of the facility up in Paramus, is actually a wetlands and probably won't be available. But there's a lot of land available in 60 acres, as you're going to hear later on, as to what it is that the county may decide to end up doing with this facility. I want to tell you why we think that this is a turning point. I'm going through very quickly a set of issues. Addiction and related mental health care crisis is creating unprecedented demand for the Bergen Regional services, some of which aren't available anywhere else. The current 19-year contract to manage Bergen Regional ends on March 14th, 2017, 5 months, a little less than 5 months now from today. The report, which forms the backbone of this BRMC session, was published on April 27th. As I said, 2 members of that panel are here with us tonight. And with its many assessments and recommendations, for one, the consensus decision to seek authority to create a new oversight mechanism to oversee Bergen Regional was not authorized by the state until late September of this year, and was really uncertain up until then. The legislature had finished its work on the bill on the 27th of June, but it took the legislature and the governor until the latter part of September to actually go ahead and create the authority for the county to move toward that oversight mechanism that will be sort of sitting under much of this discussion tonight. The county has not been able to create that new hospital authority that it can now create as yet. By mid-September, the county entity, the Bergen County Improvement Authority, that currently oversees Bergen Regional and its contractor, had to go ahead with a request for an RFP on which bidders could bid. It was originally to have been open 2 days from now, but it is not until December 2, that 6 weeks from now, those bids will be open. It's broadly held view that the selection of the next BRMC contractor must be effectively linked to a new negotiated contract. It gives the county clearly defined oversight powers and achieves transparent financial reporting, something about which each of the candidates for freeholders last week agreed. Whatever is selected, that will need to be ready to assume operational management of the facility in less than 5 months for today to assure continuity of care through adequate staffing policies and so forth. That's up in the air unless perhaps a contract extension occurs. And you're going to hear probably some about that tonight. And the public needs to know what is at stake and whether and how the county resources that will be needed to support the BRMC, how they can be available and what's involved in that. I'm going to take just a few minutes to make sure you understand the size of this facility again, and just a little bit about it. That's the picture of the various facilities that the 15 different buildings at BRMC, and you can see that long-term care involves 574 of the 1,000 beds. Psychiatric behavioral health involves 319, and acute care accounts for another 105. Now, the 60 acres is approximately, think about this, 45.5 football fields with their end zones. It's a very large area. And not all of that is being taken up currently by buildings. But these buildings are extremely old, as you can see, ages 53, 90, 91, 92, 67, 60, 48, 32. And actually, as the report suggests, none of those would meet contemporary standards for what the hospital would need to have, and so that's going to be part of the issue. Here you see that breakout of the age of those facilities at Bergen Regional. Now, for the three main types of care we just talked about, there's a very interesting separation between the number of admissions that occur for, say, acute care at 61%, and for behavioral care at 43%, as compared to the number of patient days involved in taking care of those folks. That small little 2% up there actually explodes out into a much longer set of patient days on the right-hand side. Currently, 76% of the acute care admissions are related to medical detoxification. That's a really important figure. I'm not going to sort of have you walk through, but you get some sort of sense of what we do with behavioral health services at BRMC, acute psychiatric care, mental health and substance abuse assessments, subacute intermediate psychiatric care, and then a whole raft of ambulatory specialty clinics offering a wide variety of services. And then there are three specific populations who have residential facilities out at BRMC. The Spring House, a residential treatment facility for women, provides a structured environment for recovery from alcohol and drug abuse. Summer House, a 15-bed home for individuals suffering from behavioral health and psychiatric conditions. And Harrison House, a facility is a home for individuals living with HIV/AIDS that fosters an environment of hope, ambition, responsibility, and so forth. Now, BRMC's role in the region's current health services market is important and sometimes unique. For example, at the top, you see that the psychiatric beds that Bergen Regional provides largely overshadows what's available elsewhere in the county. And when you take a look at what the BRMC is responsible for in terms of medical detox as compared to the other four major healthcare facilities in the county, that blue on the left-hand side for BRMC represents an enormous portion, the 72% of the psychiatric beds in the county, and its medical detox admissions dwarf those same admissions in any other county facility. And that's sort of the way in which we need to think about this. And then BRMC's role in the psychiatric hospitalization in the state as well as the county. Take a look at that left-hand corner over there, 4,790 admissions for psychiatric hospitals, and then the rest of it drops down throughout the rest of the state, with only a couple of those being Bergen places. Now, how is BRMC currently managed? Because that's going to be an issue tonight. The BRMC LP, formerly known as Solomon LLC, runs the operations, pays for repairs and maintenance, pays for equipment, collects payments for services rendered, pays rent to the Bergen County Improvement Authority, that's the county entity to whom it reports, pays for certain administrative fees and contracts for other third-party providers. And therefore, what goes across to the BCI is, and this is simply a piece from the report, it is the rent, the interest, and the administrative payments. Then BCI oversees the compliance currently, pays for capital improvements, collects cash receipts, and pays for debt and interest. Now, the new authority, which actually is a new state authority that allows a county to form a oversight
entity would replace most of those functions in a new function, if and when that happens, which of course there seems to be consensus agreement is a good idea. In fact, the BCIA folks themselves are very much in favor of a new authority taking over those responsibilities. It pays cash receipts and capital improvement expenditures. We'll come back to that in a few minutes. And then there's finally the adjuster fees that have money going from the BRMC LP to the county more directly than just to the BCIA. The county report discusses the financial assessments made by the consultants. Again, this is a lot of words, but it basically says the capital investment needs over the next 3 to 5 years are significant, and the items identified and the associated dollars do not address any of the functional issues or alleviate operational challenges of existing buildings, but are investments required just to keep the buildings operational. The general condition of the buildings is such that many areas are in need of significant capital investment, and one of the nice things that this report does is sort of spells some of that out. Space benchmarks for inpatient care have increased as the care models have evolved. Patient conditions have become more complex. The units of BRMC are unable to meet the space needs per current code requirements. And innovation of the existing units to meet current space would reduce the number of beds in the units and create challenges in the staffing and operating of the units, unless in fact additional space were created, assumedly by capital investment. Yet the report says BRMC's operating profitability has been near break even in recent history. That is something actually that is somewhat contested in some discussions in the county. Where will the operating income come in the future? A lot of stuff is up in the air. That's one of the sort of conundrums that I think that both the county and the people, whoever takes over this responsibility, have to look at. Subsidy revenue, the largest overall share of the revenue resources, is comprised of charity care, the funding that related to Medicaid, called the DSRIP in New Jersey, and site cost sharing. Now, charity care funding has been dropping pretty dramatically. If you take a look at that, the latest estimate of charity care payments in 2017 is $19 million, which is $16 million lower than the $36 million that was available just last year. That's something actually that one of the panelists and I have been talking about. There's an important meeting about that on Thursday, a breakfast meeting. The delivery system, this new Medicare combination that the New Jersey has set up, has in fact provided some of the relief on that, because there's 11.8 million coming in from that in the latest go-round. What I'm trying to suggest here is that there, and you're going to see this in the next slide. These are the different ways in which the operational costs are being covered by the various sources. And what you see on this chart are how uneven those levels are. That's not sort of a straight line or something, increasing cost. They jump all over the place, as I've just been suggesting by what I've been talking about in terms of the subsidy. Many factors, given this large reliance on subsidy funding, changes in cash flows from the state and federal sources can have a substantial impact on BRMC's future operations. And due to historic facility underinvestment, the total capital requirements on an ongoing basis may be much larger than in recent levels. Some of the key assessments made by the committee reports I haven't already talked about are the fact that the report points out that we have an aging population, of which I'm certainly a member, but that the number of folks over 85 will triple in the very near future. Bergen Regional plays a vital role in the healthcare ecosystems, particularly for vulnerable and at-risk populations. The areas of behavioral health and substance abuse, and particularly access to services that the Bergen Regional provides, could not be fulfilled by any other hospital in the county, certainly not the way they're currently structured. Based on first-hand qualitative and supplemental quantitative data, the quality of care, as adjudged by the panel, is appropriate and similar to other providers in the region, which is an interesting, important finding. And the majority of BRMC's facilities are past their useful life, as I've shown you in some detail already, many of them past 60 years. Certainly, none of the IT and other kinds of factors let alone even the sort of the fundamental utilities are adequate in some of those buildings. And BRMC is hindered by a long-standing community perception that being the hospital that handles care for those most at risk actually has had some impact on thinking about what it is that the quality of care looks like. Now, what did this committee find? It found that, and this is an important statement, the continued provision of healthcare services to the vulnerable population, including the elderly, indigent, and those struggling with mental health and addiction illness, is critical to the community to better ensure the continuing operations and missions of BRMC, BCIA, and the county. This was done, of course, before there was a new authority, opened up as a possibility to the county to seek partners for the medical center into the future. The initial solicitation should be open and transparent. The entire process should be guided by the vision and principles established by the committee, of which I'm not sure we'll get to sort of a full discussion of them, but we can come back if any of you think it's important to talk. Given its important role on vital behavioral health, substance abuse, and long-term care, the county should retain ownership of the BRMC facilities. This committee said its services should remain in operation and its clinical and financial performance should be strengthened to ensure its sustainability going forward. It should look to expand and strengthen those services that are underserved in the community or which BRMC has exceptional experience and capabilities, namely behavioral medicine, substance abuse, and long-term care. To continue to provide these benefits, the county should begin to look for potential partners for the facility in the future. The structure of this partnership should not be predetermined, but they should be emerge in a process where alternatives were identified, and there was a negotiation process with an entity which has strong experience in behavioral health and long-term care, continuance of existing behavioral health and abuse and long-term care services at a minimum, commitment to transparency and partnership, priority to meet safety net needs of Medicaid and charity care patients, expanding to all Bergen County residents, assurance to protect the commitments to and workplace rights of and safety of BRMC employees, and the dedication to enhancing the sustainability of operations. This issue of safety of BRMC employees and of patients actually has been part of a discussion in the county. The county should further explore the tremendous opportunity to expand access to veterans' health care services. The county should consider the expansion of services to all county residents, including those covered by private insurance, while prioritizing those most in need. Should consider all options available with regard to future BRMC partnerships. And this is a really interesting recommendation that comes at the end of the specific recommendations. Very important decision for the county and its residents should not be rushed due to contract expirations or outside pressure. An effective partnership could significantly increase BRMC's role to the value to the community. The choice of an operating partner or partners will be one of the most important factors influencing the medical center's future. And given what I told you in that second slide, that's a really important recommendation. But whether or not that's actually going to be possible is really something up in the air at the moment. It's a complex question, and I think we may get some insight into its complexity, whether or not we actually get to an answer to that question tonight. But let me end my report that there's really a very interesting additional set of discussions about principles and the way in which they apply to a variety of different factors in the BRMC discussion. And I'm not going to try to take you into it because I think we need to get onto the panel. But it's I would say it's among the young men reports that I've read, I consider it one of the better ones in terms of sort of laying out the complexity of the issues. And I hope that this gives you some sense of what it is that we're talking about tonight. And I'll stop with that. And unless anybody has a compelling question, and Rowan, if we can get the screen up, we'll see if we can get a panel up there and give you some more insight about all of this. Anything anybody has to say at this point before we go on? Art?
Yours was a very complete presentation, but I don't know when the Bergen Regional was founded, the purpose it was founded for, and how has that changed over the years.
One of the things you're going to get almost immediately in the discussion by these panels, I know from what they've said, is you're going to get an answer to that. So I can give you my summary, but we're going to hear from people who've been around this thing for a long time. Okay?